to one hour today and keep this nice and smart and efficient. The webinar is being recorded. I hope everybody's happy with that. And we've got a number of speakers today, and I'll get everyone to introduce themselves as we come to their section. But so warm welcome to the webinar. The purpose of the session is to share the findings from the early evaluation of the UCLPartners proactive care frameworks, and to highlight the progress made in 2 of the sites since the evaluation was conducted, and to share learnings as to successful implementation, and if possible provide information on outcomes achieved. And I'm going to start with a brief introduction and then hand over to Laura Bimpson from NHS England. Thanks very much for coming along, Laura. And just sort of a quick introduction just to lay the context for this work. So the proactive care frameworks were developed by UCLPartners as a major innovation to support primary care, as we're emerging in primary care from the pandemic. We know that COVID has had a huge impact on routine care, on long-term condition management, has disrupted care, and all very concerned about how we get to recovery from that position. But we know also that this is on top of the historical challenge to managing long-term conditions in primary care, where although we do pretty well, actually there's huge scope for improvement in the care we provide to our patients, the outcomes, the support for self-management and personalisation of care for people with long-term conditions. And at the start of this process 2 years ago, we acknowledged that if we're to address that, the recovery and addressing the historical challenge, we need to do things differently. So someone's just asked who's speaking. I'm very sorry, this is very bad, Jerry. So Matt Kearney, GP, Programme Director at UCL Partners. So the proactive care frameworks developed by a primary care-led team with patient and public involvement. 2 core elements: stratify your population, so you can identify those who need care, urgent care, earliest, as well as providing care for all patients, and use of the wider workforce to optimise support for education, self-management and behaviour change. As part of the frameworks, we've developed a whole range of search tools, guidance, resources, etc. There is no new guidance in there. There's no new clinical guidance or new interventions. If we want to do things differently to improve care and outcomes and release capacity in primary care, the frameworks have to be about how we operationalise that. How do we do things differently in real world primary care? So the frameworks have been really well received, really from the start of the process 2 years ago. We had over 8,000 downloads of the search tools. NHS England kindly funded 4 pilot ICSs and have absorbed the framework approach into into the proactive care at home approach. The 4 pilot ICSs, Cheshire and Merseyside, LLR, but also a large additional PCN in East Midlands called Lakeside, along with North East London and North Central London. And these pilot sites have brought huge innovation and creativity and energy to this process, working through how do you take these frameworks that are not blueprints, but how do you adapt them locally, how do you adapt the system to support implementation at scale, getting the clinical engagement and leadership, aligning incentives, etc. And the learning from the dynamic learning from these pilot sites has been really important in informing the ongoing development of the frameworks and the implementation support that we're all providing, the HSNs are providing to ICSs around the country. So huge congratulations to the pilot sites and an enormous thanks. This is never easy to do, this sort of transformation, but in the midst of the pandemic, I think it has really been a major achievement. So CHIR were commissioned to do an early evaluation of the implementation. This was funded by NHSX with support from NHS England. The evaluation is a very early evaluation, focused very much on implementation, not on outcomes. It was too early to measure that. Could I just ask everyone to mute, please, while we're speaking? So the focus on early implementation, and we're in the process of working up a commission for further broader evaluation to look at impact of the frameworks on patient care and outcomes and on the workforce. But this early evaluation was really important and fantastic piece of work conducted by Chair. Provides an important snapshot, recognising that implementation has moved on since then. And the learning from this early implementation is already being applied in the pilot ICSs and used by the AHSNs to inform implementation support in the second wave of 10 further ICSs funded by with funding support from NHS England, and it's also this learning is feeding into the blood pressure optimisation programme that is now rolling out across all ICSs using the UCLP proactive care framework. So really important learning we're going to hear about. An earlier snapshot that we are moving on from, so very much a sort of a step in the process. So we're really great, big thanks to Chair and to NHSX and to NHS England and to the pilot ICSs who've done so much to build the evidence base and contribute to the development of the framework. And before we move on to hear about the evaluation, I'm just going to pass over to Laura Bimpson. Laura, if you mind, from NHS at Home, would you mind introducing yourself? And you wanted to say a few words.
Yeah, thank you very much, Matt. Good afternoon, everybody. I'm Laura Bimpson. I'm Head of Implementation for NHS at Home. So I'm really pleased to be joining this afternoon's session. As Matt said, just wanted to say a few words. So for those who are joining the call who don't know, NHS at Home is a fairly newly established areas of work. We sit in the personalised care group and were established as part of the pandemic response to help support people to keep well, recover and manage their health and well-being at home. And we really saw the opportunity through the proactive care and frameworks to support people with long-term conditions to manage their health and well-being at home and to deliver that management of long-term conditions in a more holistic and personalised care way. So really pleased to be able to fund and support the existing sites and also hopefully some future more potential sites this year as well. So just wanted to take the opportunity, and as Matt has already said, just kind of thank our existing sites, recognise the huge amount of work and progress that has happened so far, even in the midst of the pandemic response. And it's great to see some of that starting to come through in the evaluation report, recognising obviously that was done at a very kind of early stage. I'm really looking forward to hearing more from Cheshire and Merseyside and Leicestershire and Rutland later on in the session, and also in future sessions and case studies that we'll be hopefully sharing. And the last thing I just wanted to say as well is, as well as kind of seeing the opportunity for proactive care to help support care to be delivered in a more personalised way, the proactive care frameworks have been recognised as one of the key enablers to support long-term condition recovery as well. So really pleased that in forthcoming guidance, the frameworks and the pathways will be recognised as a way to support primary care to recover as well. So I think that's all I wanted to say, Matt. Thank you.
And thanks very much, Laura. And I'm glad to see.
Oh, you've gone back on mute, I think, Matt.
Oh, sorry. Just saying thank you, Laura, and glad that your Wi-Fi survived the few minutes. I know you're having problems there. So I'm going to pass over to Alex Zeman now from CHER, which is the Centre for Health Innovation Research at City University, really great to have you here, Alex, and you've led this fantastic piece of work, so great to hear about it.
Thanks very much, Matt, and thanks for having us. Just see if I can switch to my slides. And yes, there they are. I hope you can see them. So the whole idea is to give an overview of these evaluation findings. And as Matt said before, it's a snapshot in time, and it's been a while since we've done this. And just for you all to keep that in mind. And we will be focusing on implementation side of things and deriving some top tips or key lessons learned from doing the evaluation. And I should have introduced myself. I think I forgot that. So my name is Alexandra Ziemann. I'm a senior research fellow at the Centre for Healthcare Innovation Research, which sits at City University of London. So the evaluation approach. We did focus on implementation lessons, so the early setup phase, because this is where the proactive care frameworks were in when we evaluated them last year. It was all guided by a theory of change, and I'll go into a bit more detail and present that in a minute. And the main areas where we collected data in order to do this evaluation were coming from, on one hand, a survey, a quantitative survey among academic health science networks, and we just asked, are you implementing proactive care frameworks at the moment? How far along are you? Just to get an overview on implementation progress. And we did that in June last year. The other thing we've done, we've observed communities of practice that were organized by UCLP, on one hand for academic health science networks, on the other for ICSs and CCGs to share learning. And we've observed those in order to identify some themes around that. But the main bulk of the data really came from qualitative interviews that we've done with 41 staff members at academic health science networks, CCGs, ICSs, primary care networks, and in general practices. And we've done those interviews in July, and between July and October last year. We've done those, so we looked at the four national pilot sites at the time, plus 2 additional sites. And just to say that very clearly, although we looked at all the different sites, this is not meant to be a comparison. So it was always supposed to be a summative evaluation and a formative evaluation, something where we derive early lessons in order to inform the further national rollout of this and help future implementers to implement this. So this theory of change, I want to dwell a bit longer on this, or a logic model, was really helping us to inform the evaluation and say how are we collecting data, what kind of questions do we ask, how do we analyze the data and interpret it, what topics should we look in. And it's helped us to get a program theory saying how does the proactive care framework implementation and how is it expected to lead to better care. And it starts with implementation activities. So what are sites doing in order to implement PCF locally? Then that leads to very short-term process outcomes or implementation outcomes, and then longer term has an effect on patient and care outcomes. And these 3 areas is what we were mainly looking at as part of the evaluation. Now, all of this leads to longer-term patient and care outcomes, like reduced deterioration of long-term conditions patients, or an increased retention of staff, or avoidance of pressures on the NHS. But all of this will be much longer-term and something we could not yet see because it was very, very early days. So this explained how implementation activities, which could be training, stakeholder engagement, adapting the frameworks into your local context, into your local pathways, securing funding, setting up a governance structure, using or developing implementation support tools, and sharing learning, how implementation is going across sites. So these are kind of the activities that sites were engaging with in order to implement PCF, and we were looking at those and see what works. And those led to process or implementation outcomes, very short term. Is it acceptable? Is it appropriate? Do staff and patients think this is feasible to do? How many sites were adopting PCF? And those were then expected to lead to an optimized work process in practices, optimized care processes, patient care processes, increase in personalized care, and a reduction in inequalities. And again, because this was quite early days, findings will more focus on implementation outcomes and less on those patient and care outcomes. On towards the findings. So this is really structured around those topics of implementation of patient care processes, work processes, these kind of findings, and inequalities. So just to start with, was very early stage, as Matt already said. So these are what we can present are emerging insights into patient and care outcomes, and the focus will lie on implementation recommendations. And this is mainly due to competing priorities that primary care found themselves in when they started to implement PCF and when we evaluated this. COVID vaccination rollout was very much underway, and primary care was under huge pressure. So implementing something new in those days at that time was quite difficult. And so the good thing is implementation moved on a lot since we've done this evaluation, and it's very good to hear from the 2 pilot sites after my presentation and see how far they've come since then. But this is just very important to keep in mind. It's a snapshot in time, and about almost a year ago now that the findings refer to. So in terms of patient care process, we saw that the proactive care frameworks have been welcomed by primary care networks, by practices, as a valuable improvement to long-term conditions management. And particularly the risk stratification searches were highlighted as very useful, as a very useful new way of ensuring that patients receive the right care at the right time. PCF was seen as supporting both the operationalization of the personalized care agenda and the transition towards a more holistic care approach. And PCF was perceived as providing an appropriate structure to support the introduction and integration of the wider workforce, leading to more capacity for patient care and optimized care for matching patient needs with appropriate workforce. And this quote from a GP from one of our pilot sites is illustrating this. So it says, we've managed to get another 650 more cervical smears done in one of our sites. Every site reached over 90% of their learning disability checks, and we've managed to reduce the length of the nurse consultations. In terms of work processes and experiences that workforces feedback on or fed back on, first of all, the feedback that we received was very much related to the implementation phase. And this is usually connected with much higher workload. When you set up something new, it comes with a lot of more work and different work. And this does not feed back on the routine use of primary care frameworks and how much work that, how work processes are assessed related to that, because it was not routinely used yet at the time when we were evaluating it. So what we saw is that clinicians, particularly in strategic roles, were generally very enthusiastic. They did not need to be convinced to try that out and implement the proactive care frameworks. It was quite clear to them what the benefits are. But some practices and some workforce, maybe in non-clinical roles, were a bit more reluctant to engage with implementing the proactive care frameworks, as they perceived it as, especially in that time during the pandemic, not as really feasible with current primary care pressures. And clinical staff felt that they can build much more on workforce strength and skills. And wider workforce, also non-clinical roles or wider workforce roles, felt much more integrated into practice teams when they implemented or engaged in the proactive care frameworks. And the quote illustrates this from a clinical staff member at one of the pilot sites, saying, well, for an individual clinician, it's very hard to keep up with the different offers that are out there in the community. So actually having a group of staff where that's their job to keep up to date works much, much better. And they're very skilled at motivational interviewing. In terms of patient experience and engagement, it's necessary to say that the feedback we collected was indirect, and it was reported by staff members. So because it was so early on in the implementation, patients were just started to be engaged by staff as part of the framework. So it was too early to really gather a lot of direct feedback from patients, so we didn't do it. But what we were seeing is that particularly inviting patients to reviews based on the risk stratification searches was happening a lot. And in terms of self-monitoring at home, monitoring mainly using blood pressure monitors, this was going on a lot when we did the evaluation. And so staff reported that patients felt particularly positive about the more streamlined and a more personalized and holistic care approach. And the quote illustrates this point. It's from an academic health science network operational staff member in one of the sites saying, well, one of the main feedbacks is that we got was around the education piece, that they've really loved that she's actually sat down, listened to the patients, treated them as an individual, listened to their concerns. And I think that's been really nice to be able to incorporate that type of thing in this. So it was much more of a personalized care approach. That was too quick. Patients did report that they felt generally confident and motivated about using self-monitoring or at home or remote monitoring technology, referring in most cases to blood pressure monitors because that's what happened at the time. And while some patients had difficulties engaging with digital technology to submit their readings, Self-monitoring in combination with alternative means of submitting those readings by paper or phone or however, it was preferred by many patients compared to a face-to-face appointment and being called in to do blood pressure monitoring in the practice. In terms of health inequalities, we saw that the predictive care frameworks were perceived as providing an opportunity to tackle health inequalities, for example, by supporting the implementation of PCF in primary care networks or practices that have greater deprivation or dealing with populations that have a greater deprivation. By including wider patient characteristics, so not just clinical characteristics, but demographic, ethnicity, or any kind of other socioeconomic background characteristics in the risk stratification searches, and by offering a more holistic and personalized care approach. And in terms of digital exclusion, which was, of course, rising from an increased application of remote monitoring that comes with applying predictive care frameworks, and again, particularly referring to blood pressure monitoring at home, practices were offering a much more flexible approach or hybrid engagement model with the option to use remote monitoring alongside face-to-face appointments or having alternative means of providing self-monitoring readings, such as well in this quote, reflects this flexible approach that some practices took. So the PCF searches, it's based on their comorbidities, the age, ethnicity, blood pressure. We are doing a clinical review now, so we can think how best to serve those patients. For example, people with sight impairment, severe arthritis, learning disabilities. Are they self-reporting, working with a carer? Do they come into the practice, or do we send a district nurse? So different strategies for different patient needs. And to conclude, it doesn't go further. Here we go. That's the conclusion slide. I want to go back to the main focus of the evaluation, which was on implementation and implementation top tips or recommendations. And so this is really presenting those key lessons in terms of what works when you want to implement predictive care frameworks. And it's a layered approach.
I'm not sure I understand.
Sorry, that's my watch talking. So it's a layered approach, which starts with, of course, everything that has to do with the predictive care frameworks themselves. So it's around having to implement the searches and the stratification, selecting wider workforce, training them, adapting predictive care frameworks into the pathways, the local pathways, or adapting the pathways to accommodate the PCF. And there's a lot of help, of course, available and support available from UCLP to do this. And there's a next layer around making sure that the predictive care frameworks can be delivered on a day-to-day basis. And for that, it's really important to think about having to make digital resources work. That's mainly referring to the practice information systems, having embed that and work together with predictive care frameworks, but also technology. When you think about remote monitoring, there needs to be a way of a set way or a plan how to distribute those, how to fund those, how to procure them, how to get them back, how to get the readings back, just as a way of, as an example. And of course, everything needs to be funded longer term. So having the procurement sorted out is the important part here. And the last layer is really something around this initial setup phase or the implementation support. And this will fall away as soon as this becomes day-to-day business. But for the initial setup phase, there need to be specific or dedicated resources in place and dedicated activities going on. And these are around knowing your local context, adapting predictive care frameworks to the local context, engaging stakeholders, identifying stakeholders that are involved in the implementation of this, securing funding for the initial setup phase, making use of levers or incentives, setting up a project governance structure, having an evaluation running at the same time, so you know actually is this working locally or is it not working, and what works and what doesn't, and this shared learning piece. So having maybe a community of practice or joining one that exists, and just not being alone with this and not reinventing the wheel either makes it more efficient. And there are a few top tips I would like to end on with that we've identified from the evaluation. And first one is that predictive care frameworks can particularly support practices concerned with managing their backlog and engaging vulnerable population groups. PCF can provide a structure to involve existing and new wider workforce roles on a larger scale, and there is also funding available from the additional roles reimbursement scheme. it's important to start with, or that's what sites found. They found it more useful to start implementation in a smaller number of PCNs before rolling out across the whole system. It was clear that you can't do PCF implementation in 6 weeks based on the resources you have available, but it takes a lot longer and it needs dedicated resources and funding. And there is help available, or it might help if one could find local or national levers, and aligning implementation or rollout with those levers helps a lot, or has been found to help a lot. Regularly engaging with all involved stakeholders, and from the start, particularly nominating a senior clinical champion was seen as supporting PCF implementation. The shared learning piece I already said, so there are current communities of practice and other local sites set up communities of practice, and that was perceived as very helpful. And there is, of course, implementation support available and resources available from UCLP, from HSNs and ICSs from the pilot sites, which can help future implementers be more efficient. And a very important piece that we found, because implementation moves on so quickly and the context changes, particularly with COVID, it was important to continuously review the implementation progress, barriers and enablers, and then pragmatically adjust your implementation strategy towards that. Thank you very much.
Wonderful. Thank you so much for that, Alex. Really comprehensive whiz through. What we're going to we'll take questions at the end. We're going to move on now to Arlene Neville, and I'm not sure, Jess, whether you're also joining in, but if you mind both introducing yourselves, and just looking at the time, if we try and do this in about 13 minutes, that would be great. So thank you. Over to you both.
Thank you, Matt. So yeah, we're going to do a trio on this just to complicate things, but I'm safely assured we're going to stick to time as best we can. So my name is Arlene Neville and I am Head of Transformation for LLR CCGs, that's Leicestershire, Rutland. I currently head up a programme within the primary care transformation world, and I'm SRO, as part of that, I'm SRO for proactive care and the delivery of the pilots, being a pilot site last year, and I'm going to talk a bit about what that means for us in the future. Maybe Jess, when you come on to your bit, you might want to introduce yourself then. Perfect. So, and hopefully we will have Rowan, who's our GP clinical lead, come in to do a slide for us, because it really is a bit of a collaboration, so it'd be unfair of us to not present ourselves as such. So I'm also acutely aware that lots of you will possibly have heard me talk about this quite a lot over the last year, and some of you may not at all. So I'm hopefully going to try and get the pitch right in a way in which we can sort of stimulate some conversation in the Q&A section at the end. And we're always happy to try and take conversations offline if needs be. So we will try and keep this as concise as possible. So Jess is looking busy with her eyes there, so I'm assuming she's going to pop this slide up in front of me. Is that so right?
I think UCLP are...
Oh, lovely. So are we going to have the slides up?
Alan, are you able to put the slides up?
Awesome. Thank you. So as they whiz through, following on nicely from what we've heard from Matt and Alex, for us in Leicestershire and Rutland, if we go back one slide, please, and another one. Oh, are we missing a slide there? That's the one. Thank you so much. Thank you. So where do we start? Right. So for us in LLR, we, like a lot of systems, had a lot of energy behind long-term conditions. We had always programs looking at improvement areas and long-term conditions, and had a really strong emphasis on risk stratification. So our practices were quite used to having some energy behind risk stratifying and needs-based profiling and so on and so forth. So when we were sort of approached, or when our PCNs were initially approached to look at proactive care at home and support in the implementation of it as a pilot site, we no surprise, we had a lot of PCNs that were really interested in taking this on board. And so as a CCG, what we did is quite quickly made a decision to try and have a very system approach to delivering this as a pilot site rather than it running at a PCN level. So that's the first thing we perhaps did, which might be slightly a bit different to the other sites, is we sort of gathered it up and thought, is there a way in which we could do this bigger and enter into a marathon rather than a sprint? And people have heard me use that analogy a lot, but it feels so real. So for Leicester and Rutland, our footprint looks, we've got 26 PCNs and we've got 133 practices. We were 3 CCGs, we've come together as 1 CCG and we're just evolving into an ICS. Without the boredom of all of that entails, it's important that we understand the context, never mind COVID, that we're working in. So for us, last year, we basically said we want to take this on as a system level and look at ways in which we could roll on the back of a lot of the long-term conditions work we've done and embed it in by working with 2 cohorts. The first cohort, which were called our trailblazers on this plan on a page we call, which is working with a group of the willing, a set of PCNs and practices who wanted to work with us to try and implement this. And then we had a separate group which we approached, which was a group of practices that were really struggling with the greatest scale of backlog that we were able to quantify. So obviously they needed very different approaches and so on and so forth. So that was our, what we're called here on the chart, a blended approach. Needless to say, along came Q4 last year, where we were all turned on our heads. We all had great ambitions of sort of working with these, setting up a community of practice, involving clinical champions, which we'll talk about a little bit later. And then Omicron came and sort of hit all of us in healthcare and in general care like a brick wall, and we had to really rethink our energy and focus as a team and our ability to make this change happen how we initially thought. So what we did is, on the back of proactive care at home, we commissioned a very discrete piece of work, which was supporting practices with their highest risk patients identified through the proactive care frameworks. And we commissioned independent providers to support practices with doing those reviews. So we set off on this marathon, but had to do a little divert through a few fields over a couple of fences to try and use the burning platform that we had with backlog, because what we definitely learned through initiating proactive care at home with practices is that there was a real will and a want for help. The problem was very tangible. You could touch and feel and see it. Behind every cough instance was a patient. And so the case for change was so real. And what we really wanted to do as a team is use that to keep our eyes on cough work in Q4 whilst cough was switched off in effect. And so we did that by commissioning 2 providers to work with us to do reviews of patients with COPD, which was a particular, it'll be no different to any other system, I'm sure, particular area of high burden. Support practices with doing the COPD reviews for their most high risk patients identified through proactive care at home. And we had a separate provider do hypertension, AF and asthma reviews. So you can see there basically in the space of 7 weeks, they worked with about 100 practices, because not every practice had high risk patients in them, as you can imagine. So it was really about focusing them in on the areas of greatest need. And they completed 4,787 actual reviews. And we've done a whole evaluation piece on that because we learned a ton of stuff through that process. Actually commissioning independent providers to support GP work was a very bold decision we had to make while cough was switched off. So we learned loads through that. And so Jess is going to now talk us through some of the actual ins and outs of proactive care at home, and then hopefully we can have Rowan talk to us about some of the clinical champion area and I'll come back and talk about the way forward for the next year. Thanks, Jess.
Thank you. So good afternoon, everybody. My name is Jess Lucas. My title is Proactive Care Programme Manager. So last year I was on a year's secondment to work solely on proactive care at home and the backlog and all of that kind of thing. And the good news is that this role has just been secured for another year. So I've had a few celebrations over the last month. So it's my job to make this happen, really, and I'm not going to go through everything that's on this slide, but it just gives a little bit of a flavour of what we've been up to for the last year. I think probably the key bits that I'll pick out, firstly, is the big box, the 45,000 patients. So since September, they are patients who hadn't been seen, who are kind of the reason that proactive care frameworks were designed, was those patients that have been left behind. So since September, and this was up to the end of April, so quite recent, that's how many patient instances, and we have to say instances because some patients will have dual conditions that we've managed to see, or not me personally, obviously, but our clinical teams. So the way that we can do that is that we now have monthly QOF, which is fantastic. So our Leicestershire Health Informatics Service are able to go into our GP practice systems and pull off that information for us. So previously we've had yearly, and I'm sure everybody's the same, not only yearly QOF, but also then 6 months out of date, which has not been helpful at all. So that's one of the kind of key things that we now monitor. So there's 20 indicators that include proactive care at home, but also include a few other bits like mental health, I thought, while we were there. As Ali mentioned, we've been engaging with our struggling practices, so we've sort of engaged with 9 of those now, and Rowan will talk a little bit about the clinical champions and the work that they've been doing to kind of make this real on the ground. We now have the searches from proactive care at home are now built into our systems, so both System 1 and EMIS. We are, I think it's 91% System 1 with a few EMIS, so they're now built in, which is brilliant. So whenever UCLP release anything new, we're able to update for everybody, which is fantastic. And it means that they're then accessible for everybody. And then we've been, something else that Rowan will mention is about webinars. So we've been training our wider workforce. We have a training prospectus that goes out, and we're also looking at more remote monitoring now as well. One of the things that I particularly wanted to show, and hopefully this slide isn't too small, maybe you can zoom in, is showing kind of the overall impact that we've had, or that we are perceived to have had. So when we started, so pre-ish COVID, which was March 2020, just as things were kicking off, over that year, as everything was kind of closed, we ended up just over double the amount of patients that hadn't been seen, which is the number at the top there, so 104%, and they are patients who should have been optimised through QOF but hadn't been. And then the green line shows where we started with implementing proactive care at home, and then as you can see, it's now started to come back down again over the year, which is fantastic. I have to note that there will be other things that will have influenced this, I'm sure, but it's lovely to see that it's making a difference, and that we're now 63% kind of back towards where we need to be on what we're calling a normal QOF year. There's still plenty of work to do behind that, because although there's that baseline, is that a good baseline, and we've got more work to do, but that's just hopefully illustrates a little bit of what's happened. So I will pass on to Rowan, and he will hopefully introduce himself.
Yeah, good afternoon, everyone. My name's Dr. Rowan Sill. I'm a GP working in Leicestershire, and one of the kind of board members for the CCG that took on the proactive care clinical lead role. So we, as Jess and Nardine have both said, that we wanted to take this on as a system and make sure that, you know, this kind of way of working with risk stratification and upskilling of our primary care workforce in the wider sense would be really kind of taken on by the whole of LLR. So in order to enable that, we knew that it couldn't really be done with just one person trying to send out these messages and trying to workforce map, and we needed to get these messages and really clinicians into every single area in LLR, in particular targeting those practices with the biggest backlog that we mentioned on the first slide. So in doing that, we put out expressions of interest for 5, as many clinical champions as we could get, and making sure that we tried to encompass as many areas of general practice workforce as we could. In response, we did get 4 GPs, a pharmacist, and also I think there was a nurse practitioner as well that joined us briefly, but then because of other commitments couldn't stay. We're engaged with 9 practices that had the largest backlog, and all of those had visits from the clinical champions to kind of go through the searches, how to find them, how to risk stratify, and bearing in mind that this is in this time when the workforce in primary care was under particular pressure from lots of cases of Omicron. We were going through a wave of that, and practices were basically trying to firefight daily acute medical needs, and very much so the long-term conditions agenda was put on the back foot because of the pressures that they were getting every day with hardly any staff in place. The way that the system workforce maps the different workforces and can bring in our staff who are all trained at the same level with the kind of frameworks really helped move that work around practices and make sure that we're not just using GPs and practice nurses, but we're using the wider R staff. So we're very grateful to the clinical champions. One of those is on the call today. And we've engaged with as many practices face to face or in webinars to try and improve their long-term condition work. The communities of practice were made up of basically practices that really took an interest right from the start. So what we called our trailblazers, and we had monthly meetings with them during the first kind of 12 months of implementation to make sure that any questions they had were answered, and we had input for the and the Health Sciences Academic Network as well on there. And we wanted to make sure that the clinical champions, when they went into practice, we're actually training a lead for that practice. So we're actually devolving the work to somebody in the practice that could champion the proactive carers at home, because there's really so many areas to it that it's difficult to maintain that kind of level of support, and actually training the trainers within the practices was the model that we were looking for. And finally, the workforce upskilling, we actually put into action, working with our kind of academic hub in LLR, a whole timetable of webinars and training sessions that we did on all of the frameworks, and certainly from a kind of a nurse, GP, and clinical pharmacist point of view. Some of the feedback we got was really good around that, and we did an hour long with lots of interactions, and some of the guys from UCL as well took turns in presenting some of those, which was really a lot of and I think there were around 50 to 60 people on each of the calls. So just moving on to the last slide, I'll hand back over to Arlene.
Actually, right, could I just cut across? I'm so sorry, we're run very short of time, and thank you so much for so much information and so helpful to hear. But what I suggest is, if possible, we could move on to Rhiannon, who's going to talk from a Cheshire Merseyside perspective, and then we'll probably have a very limited time then for questions. But I think we've started a conversation here, so so sorry to cut across you both and Arlene. Rhiannon, can I bring Rhiannon in here and move on the slides, please, for Rhiannon?
Do you want me to share the slides from my screen?
If you have them, thank you.
Is that sharing? Can you see?
Yep, that's perfect. Thank you.
Brilliant. Oh, thanks, Matt, and thanks for inviting me to come and speak today. As Matt mentioned, my name's Rhiannon Clark, and I'm a Programme Manager in the Innovation Agency, which is the academic health science network for the North West Coast. So I'm going to use my time today to tell you about some of the work that's been done in Knowley based on the proactive care asthma framework. Just move it on. So the challenge in Knowley. So I just wanted to briefly touch on why asthma is such a big problem in Knowley. Knowley is the second most deprived borough in the country. It's got high levels of unemployment and health inequalities compared with the rest of England. It faces continuing and deepening challenges presented by an ageing demographic and unhealthy lifestyles, as well as significant areas of deprivation which impact negatively on population health. So down here you can see I've generated a couple of heat maps using AstraZeneca's respiratory outcomes site. So this first one here just shows us that Knowley has an above average mortality from asthma despite a below average prevalence. And the second one just illustrates the SARBA overuse in Knowley and surrounding areas. So SARBA overuse is defined as more than 3 SARBAs in 12 months, and actually over 50% of patients in the UK overuse SARBAs. And to add to that, SARBA overuse is a problem for environmental sustainability because the amount of greenhouse gases emitted by the inhalers are approximately 3 times higher in the UK than other European countries. So in early 2020, work had begun to develop a Knowley high-risk asthma clinic, K-HAC, via the Knowley Community Respiratory Service. The initial aim was to identify approximately 500 high-risk patients, that is, patients that had over 3 SARBAs and less than 6 ICS LARVAs or triple canisters per year. They were going to offer spirometry and a consultant review of complex patients. And that project was funded through a MEGS grant from AstraZeneca, which are now called DOGS, which is Donation of Goods and Service. And that was used as a seconded from the Community Respiratory Service to run the clinics. But then the COVID-19 pandemic hit. And so that meant that the original model became untenable because there were restrictions on spirometry and other aerosol generating procedures. So it was during that time that the UCLPartners produced their frameworks, and those frameworks were introduced to the Knowley team by the Innovation Agency, and it was perfect timing. So we worked closely with Hassan Burhan, Hassan Argamanka and the Knowley respiratory team, who then modified the UCLP searches and developed a new model that was just better suited to meet the needs of the local patients. They also incorporated things like FeNO testing and asthma control tests to determine how well controlled the patient's asthma was. So this work began with Primary Care Knowley, which is a confederation of 5 GP practices operating from 11 sites across Knowley. The practices provide primary care to over 52,000 patients, which is about 1/3 of the Knowley population spread across all 3 PCNs in Knowley. I'm not going to go into this slide, don't worry, in too much detail. I just wanted to just briefly show you how the criteria was adapted to better fit the population in Knowley. I mentioned earlier that SARBA overuse is a massive problem in the area, but so's under prescription of inhaled corticosteroid inhalers. And that preventative medication is the bedrock of good asthma management. And the team felt that it was really important that those patients were prioritised for review first. So we classed those as the high-risk patients. The median patients were those who were on ICS but were receiving 6 or more SARBAs per 12 months. And the low-risk patients were those who were on ICS and less than 6 SARBAs. So the patient reviews themselves were actually different from normal annual long-term condition reviews, and they were conducted as a mixture of face-to-face and remote. Face-to-face enabled the nurse to include FeNO testing in those reviews. Each review lasted about 40 minutes with each patient, and that allowed the nurse to conduct a medication review, inhaler technique review, and also include an educational component to discuss the patient's condition and the importance of preventative medication. I mentioned earlier about FeNO, but I just wanted to just briefly go into that in a little bit more detail for those who aren't familiar with it. So the FeNO test measures fractional exhaled nitric oxide in the breath of patients and provides a score. And this is a biomarker for asthma, which provides an indication of the level of inflammation in the lungs. So a high FeNO level means there's untreated eosinophilic inflammation present. And that increases the likelihood of a correct asthma diagnosis and suggests that the patient will respond to corticosteroid medication. So one of the difficulties they have is that if a patient has a diagnosis of asthma and they've got new or persistent symptoms, do they need their medication adjusting? So FeNO level can help give the clinician and the patient confidence that there is eosinophilic inflammation present that's currently untreated. And that might require better adherence, better inhaler technique, or more effective dose of the corticosteroids. So we reran the initial EMIS searches in February 2022 and compared the results with those from the original searches in October 2020. And as you can see, the number of high-risk patients was reduced by almost 60%, which you can see translates to an increase in the number of patients in the low-risk group. As well as rerunning the EMIS searches, we also looked at each patient's records 6 months post-review to see the changes in their medication. So I've popped a few of the outcomes on this slide. as well as the reduction in the high-risk patients. There's also an achievement for environmental sustainability. We had a reduction in the number of SARBs prescribed, and that meant that there was a massive reduction in the number of patients on 6 or more SARBs per year. And we've also doubled the number of patients now on 3 or fewer SARBs, which was really good. I just wanted to highlight some patient feedback that we've had. So as Alex mentioned earlier, one of the main feedbacks we've had is around the educational side of these reviews. The patients really loved that the nurse had time to listen to them and explain in more detail about their condition and about their medication. So that's something that we felt was a really, really nice aspect of this approach. So spread and adoption. As has previously been mentioned, the UCLPartners frameworks were adopted by NHSE and NHSX, and they provided funding to Cheshire and Merseyside. The Innovation Agency are early adopters of the work, in part due to this Knowley Asthma project, and we were chosen as one of the 4 national pilot sites. And due to the encouraging results to date, other GP surgeries within the Knowley PCNs agreed to support the Physician Associate Programme led by the Heart and Chest Hospital, and that was funded by the Additional Roles Reimbursement Scheme. And they committed to extend this piece of work to their patients using the physician associates to lead the stratification process and run the clinics, while also being supported by admin teams, healthcare assistants and clinical pharmacists. Training and rollout started last May. The asthma specialist nurse running the original clinics supported the training and rollout of the new clinics. The Innovation Agency supported her secondment for an additional 4-month period, which enabled her to train the physician associates and make sure the clinics were up and running, and that staff in the practices were also supporting the work. The work done in Knowley was also recognised nationally. It was shortlisted in 2 categories for the HSJ Patient Safety Awards in September and for the main HSJ Awards in December. So in conclusion, the work couldn't have happened without integration between the secondary care-led community respiratory team, primary care Knowley, UCLPartners and the Innovation Agency, and of course the initial dogs provided by AstraZeneca. This was never seen as a one-off piece of work, and it's exciting now to see the approach embedded in the PCNs, using the physician associates employed under the Additional Roles Reimbursement Scheme. Thank you.
So thank you so much for that, Rhiannon, and whirlwind tour, an awful lot of information today, and we've had just 1 hour, and I guess it's part of the working through COVID and working from home, we've all learned to try and keep our meetings really focused, and sometimes actually I think you benefit from a little more time, but this is the start of a conversation. We have just five minutes left. There's been some chat in the chat, as it were, some questions being answered. The slides will be circulated. Any questions that people would like to raise in these last few moments? So please raise your hand electronically if you do. So I'll just wait while people consider that, whether any questions, and yeah, it's a challenge if there's only 5 minutes and there's an awful lot to ask and think about. I've really enjoyed today, and I think it's fantastic to have the evaluation as a focus for discussion. The evaluation has been as you know, as described, an early snapshot, and things have evolved since then. The evaluation has informed the learning, and so the great work we've heard about from Eleanor and Cheshire and Merseyside has been very much informed by that. I think important that it seems to be important messaging for me was the evaluation has shown some reported impacts. It was early evaluation. There was going to be always going to be a limit to the amount of evidence it generated, but it's given us some reported impacts and emerging insights into impact on patients, into potential for impact on health inequalities. This is not evidence of change, but they are early insights and help us understand, is this likely to work? How else could we adapt it? So I think it's really important learning from that perspective. And it's been fantastic to hear the the case studies, and I'm really sorry, LLR, for cutting you off, because the richness of your your learning is really great, and we need to find perhaps more effective ways of spreading that, and Cheshire and Merseyside. But I think important learning about your approach in LLR to the system approach, making the whole system, recognising this is a huge transformation, and so how do we mobilise the system to make this happen? And then in Cheshire and Merseyside, in Knowley, I think particularly your focus on adaptation for local use, adapt the searches, adapt the pathways, and that was always one of the core principles, that these cannot be blueprints but have to be for local adaptation. So you've really generated a lot of learning from that. But I think, and I am, as I'm talking, I'm looking for hands. There are no hands have come up yet. So I will just finish off. But it is a major transformation that we're talking about in primary care, and resources are not enough, and we're never going to be enough. There has to be structured, systematic support for implementation, and that has to include local adaptation. It has to include local clinical leadership, engagement and leadership, and Rowan, exemplifying how you've generated that in LLR. And if we don't put the energy into that, this transformation is not likely to work. And I think that's really critical learning. It was reflected even in this early implementation. And Darlene, yes, I can see you've got your hand up.
Sorry, Matt, I was just trying to fill a gap there, but I put it into the chat, which is really around, is there a way in which, because it feels like we're really great at measuring process, because it feels really easier to measure process, but how do we ultimately know if patients are optimised and reviewed quicker and proactively, that they are, if they get an exacerbation of their condition at 2 a.m. in the morning, they're less likely to go into hospital? That's the ultimate test, isn't it? And I'm automatically thinking about PAM and the personalisation agenda. And is there a way in which we could be supported to embed person-activated measures or patient-activated measures into our work going forward? I think we need a lot of help with that locally, and how might we do that? I'd be really keen to explore some options from, I know, Laura Bimpson in the personalisation world. Is there a way in which we could do that? Because I think that's the litmus test for me. Are patients feeling more in control of the disease and less likely to need acute care?
Yeah, absolutely, and I think that would be a really exciting area to take forward. This is transformation, and it is to transform patient care and patient experience and patient outcomes. So but I think there are two separate issues in there. One is what you just articulated, for example, using patient activation interventions and patient activation measures. But the other is, how do we know we're having an impact on outcomes for patients? And we will see that further down the line in heart attacks and strokes, but we will see it if we're optimising asthma care and we're optimising blood pressure, and we have the numbers to show that. We know there's a straight line of evidence between that optimisation and outcome. So those are not process measures, those are important intermediate outcome measures, and we are absolutely looking at how we now incorporate that sort of measurement into the next evaluation. And that brings us to 1 o'clock. So thank you very much, everybody, for attending, acknowledging it's a short time, and we'll have discussions about how else we can take this conversation forward. There will be further evaluation, but there is more discussion to be had here around the learning from the pilot sites, further reflections on the early implementation, evaluation finding, etc. So we'll explore that internally and see how we can facilitate more of these conversations. So thank you very much indeed, everybody, and look forward to seeing you again. Bye now.